We will talk about peripartum hemorrhage. Yes, the patient is young, maybe patient doesn't have any comorbidity, but risk of mortality is very high if not timely intervened. So proper identification, proper plan, proper resuscitation should be in our mind to manage these patients. In this section, we will discuss that. So first part of the video, I would discuss how do we classify the peripartum hemorrhage. That is hemorrhage with before delivery of the fetus, antepartum, and after delivery of the fetus, postpartum. Then common etiology of antepartum and postpartum hemorrhage I would discuss in this section only. And special things, special concerns which we have to keep in mind while doing pre-anesthetic evaluation of a patient who are predisposed to peripartum hemorrhage. We have to know, I will discuss in this section, and also special concerns in their anesthetic management, the general concerns in their anesthetic management. After discussing this, the specific concerns in different types of antepartum hemorrhage according to the etiology which we have to take, I'll discuss in this first video itself. After this, in my second video on peripartum hemorrhage, I will discuss about management of postpartum hemorrhage. So let us start our discussion with a division. As I said, that it is before birth, then antepartum hemorrhage, mostly seen after 20 weeks of pregnancy, and after birth, that is postpartum hemorrhage. Could be early or late according to the time it presents. So division can be in two division: antepartum, that is before birth of fetus, and postpartum after the delivery of fetus. Now, first thing we need to know the common etiology of antepartum hemorrhage and postpartum hemorrhage. Most of the antepartum hemorrhage presents after 20 weeks of pregnancy, and 50% of the etiology of antepartum hemorrhage constitutes of two important clinical conditions: abruptio placenta and placenta previa. So, placental abruption and placenta previa, that is the two most important etiology of the antepartum hemorrhage, and they constitute 50% cases of antepartum bleeding. There are some less common cases, like we have the uterine rupture, which is a rare cause, and your vasa previa, which is again a very rare cause of antepartum hemorrhage, which also I will discuss. So what is placental abruption? What do I mean by the word placental abruption, or popularly called abruptio placenta? Now, abruptio placenta is partial or complete abruption of the placenta, which is normally implanted in the uterus. So, placental abruption refers to premature separation of normally implanted placenta before the birth of the fetus. Implanted placenta before birth of fetus. And the clinical feature depends on the degree of abruption, that is complete or partial abruption, and whether acutely abrupted or a chronic condition, a slow abruption. So, clinical features depends on degree of separation, and whether it is an acute or chronic condition. And mostly it is a clinical diagnosis. Now, if patient doesn't have placenta previa and patient has antepartum bleeding, then abruptio placenta is most common clinical diagnosis. Patient presents with the pain, uterine tone may be increased, maybe contraction of the uterus may be seen. So it is mostly a clinical diagnosis. Because the other condition which I am going to discuss, the other etiology, that is placenta previa, it is ultrasound diagnosis. It is confirmed by the ultrasound. So the other one is your placenta previa. Now, how do I define placenta previa? Placenta extending over cervical os. So in abruptio placenta, placenta was normally implanted. The normally implanted placenta got, let's say, disengaged. It got normally implanted placenta got separated from the uterus prematurely. That was abruptio placenta. But placenta previa is abnormally implanted placenta over the cervical os. So placenta previa, placenta extending over cervical os, and this presents with mild to moderate painless bleeding, without pain or uterine contraction, right? So this is just producing painless bleeding, and when the ultrasound is done, then in ultrasound the confirmation is done. So ultrasonic confirmation, ultrasound, it is confirmed by ultrasound. So ultrasound diagnosis. Okay. The other common etiology, uncommon etiology of let's say your antepartum hemorrhage is your uterine rupture. So uterine rupture is a very uncommon etiology of antepartum hemorrhage, and this mostly happen if patient had a previous LSCS. In developed country, previous LSCS, normal trial of the labor is given, and sometimes this can lead to uterine rupture. Or in developing country, prolonged obstructed labor can lead to uterine rupture. So patient with previous LSCS or trauma, or let's say uterine rupture because of the prolonged obstructed labor, all can result in uterine rupture, and this is not common. This is a rare etiology. Then another rare etiology is vasa previa, that is fetal vessel crossing the cervical os. So vasa previa. So vasa previa is fetal vessel passing in close proximity to internal cervical os, in close proximity to internal cervical os, and this would present with bleeding, and the bleeding in vasa previa is mostly from fetus extra sanguination is more commonly happening because it's bleeding from the abnormal vessel. It's called vasa previa, and this is again abnormal. It is again, let's say, a rare cause. So these two are rare cause. Okay, so this is the etiology of antepartum hemorrhage. More than 50% of the cases, either abruptio placenta or placenta previa, and some rare causes like uterine rupture, vasa previa, and some other causes can also be there. Okay, so this is the etiology of antepartum hemorrhage. Now coming on postpartum hemorrhage. So how does postpartum hemorrhage is defined by WHO? The postpartum hemorrhage is defined as blood loss more than equal to 500 ml within 24 hours after birth. So within 24 hours after birth, the blood loss of more than equal to 500 ml. And severe postpartum hemorrhage is defined as blood loss more than equal to 1 liter within same time frame, that is 24 hours after the birth. That's called severe postpartum hemorrhage. And American College of Obstetrician and Gynecologist, they defined the postpartum hemorrhage as cumulative blood loss of more than equal to 1 liter or blood loss accompanied by signs and symptoms of hypovolemia within 24 hours of birth, regardless of the route of delivery, whether it's a cesarean delivery or it's a normal delivery. If more than 1 liter with signs and symptoms of shock, then it is called it comes under the category of postpartum hemorrhage. And postpartum hemorrhage can be classified into early and the late. When does it present? So it could be early. Early is within first 24 hours after birth, right? And late is from 24 hours to 12 weeks after birth. 12 weeks after birth. So early and late postpartum hemorrhage. Causes can be remembered by remembering the 4 T's. That is, uterine tone not achieved, uterus has not contracted. Then trauma to the uterus, uterine rupture has or laceration of the uterus has happened, or tissue, that is some retained placental or fetal product, or thrombin, that is coagulopathy. So 4 T's: tone, trauma, tissue, thrombus. So coming on the causes, as I said, we need to remember it on 4 T's. T for tone, that is patient has uterine atony, uterus has not contracted properly. Then trauma, trauma means laceration or rupture, laceration or rupture. Then tissue, tissue that is retained tissue or blood clot, retained tissue or blood clot. And thrombin, that is coagulopathy, thrombin, that is coagulopathy. So these are the 4 T's of postpartum hemorrhage, and it's a medical emergency, right, and needs to be managed immediately. Stage-wise based approach to placental, the postpartum hemorrhage with criteria that define each stage is stage 0, that begins with the delivery of neonate and refers to normal postpartum bleeding. So this is, let's say, normal. Stage 1 reflects the initial sign of abnormal uterine bleeding following delivery and should trigger the initial bedside interventions like resuscitation, like fluid, like if there is a laceration repair of uterotonic drug has to be given, then it has to be started, or manual removal of placenta in case we are suspecting a retained product. So that is just stage 1 when the warning sign starts. Then stage 2 is declared when the bleeding continues or the patient continue to have unstable vital sign if after initial resuscitation despite initial intervention. And stage 2 should trigger escalation of care. Now we should be very, very cautious, and it should the care should be escalated and things should be managed on emergency basis, on urgent basis. Stage 3 represents severe hemorrhage, more than 1500 ml of blood loss or coagulopathy. And stage 4 is defined as cardiovascular collapse. Now, the role of anesthesiologist is in each stage except stage 0, which is maybe a normal stage. So, our role begins from stage 1, and we let's say contribute in resuscitation and prevent the patient going into stage 3 or stage 4 when the things can become unmanageable. So we need to identify signs and symptoms of hypovolemic shock and need to quantify on those signs and symptoms how much blood loss is happening in the parturient. And we also need to identify the early warning sign, the maternal early warning sign, that is MUSE. And we need to escalate our care, maybe shift the patient to ICU, etc. So blood loss, what percentage of blood loss will produce what sign, right? If it is 10 to 15% blood loss, that is 500 to 1 liter, the systolic blood pressure would be normal or maybe more than 90, because these are young patients with a good sympathetic tone. So as a sympathetic, let's say, response of the body, the blood pressure may be normal or systolic blood pressure just above 90. And patient may present with palpitation, little lightheadedness, maybe orthostatic hypotension, no or mild increase in heart rate, right? So basically little palpitation and lightheadedness patient will feel. Then if it is 15 to 25% of the total blood volume loss, that is from 1 to 1.5 liter, then the systolic blood pressure would start falling. It would be, let's say, between 80 to 90 mm of Hg. Patient will complain of weakness. She will have sign and symptoms of increased sympathetic stimulation like sweating, tachycardia, tachypnea, right? And here we have to start our vigorous resuscitation. These young patients we may lose if proper resuscitation is not done. Then if 25 to 35% of the blood loss, that is 1.5 to 2 liter of the blood loss has happened, the systolic blood pressure would further reduce to 70 to 80 mm of Hg, and patient will have decreased mental awareness. Now the CNS symptom will start coming. The perfusion to the brain has started decreasing. So patient will have confusion, pallor, we'll see visible pallor, patient will start having oliguria, right? Then tachycardia would further increase, and cool and clammy skin, cool and clammy skin will appear. Now, if the blood loss is 35 to 45% of total blood volume, that is from 2 to 3 liters, then the systolic blood pressure would further reduce, and patient will become more, let's say, mental let's say consciousness of the patient will further reduce. So lethargy, air hunger, patient may go into anuria and may collapse, and heart rate may further increase to 160 mm of Hg. So if you are seeing a systolic blood pressure less and very intense tachycardia, then you have to be very careful and start with a very good fluid resuscitation. If patient doesn't have a cardiac issue, she doesn't have any pre-existing cardiac illness or cardiac comorbidity, or no kind of cardiomyopathies is suspected in her, then a good volume resuscitation and with blood and blood products or with crystalloids and colloids should be started immediately. We should start with crystalloid and colloid, and we can go with blood and blood products according to whatever is required. So good resuscitation is key to saving life of these patients. If patient has cardiac issues, then we have to be very careful in giving fluids. Maybe we will only give the blood products, and we may start the inotropes to the patient. Now, what are the early maternal warning signs that we should look for? So maternal early warning signs, that is, we call it MEWS, right? So if these signs are present in the female, then we definitely should escalate our care, shift the patient to ICU to save the patient's life. If systolic blood pressure is less than 60 or less than 90 or more than 160 mm of Hg, diastolic blood pressure more than 100 mm of Hg, heart rate less than 50 or more than 120 mm of Hg, mostly in hemorrhage it would be towards higher side, and systolic blood pressure would be towards lower side. Respiratory rate more than 30 breath per minute. Saturation of the patient would start decreasing. Oliguria, in let's say urine output for more than 2 hours, less than 35 ml per hour. Patient is agitated, confused, unresponsive. Patient may complain of any additional signs which was not present in her. All should warn us. These are maternal early warning signs, and this is a bedside tool to predict morbidity and mortality in patient. If these signs are present, then patient may have a poor prognosis if not intervened properly. So we have to look for this, right? So this is maternal early warning sign. Now, how do we manage as an anesthesiologist? How do we manage the peripartum hemorrhage? Number of patients are at risk of peripartum hemorrhage. They are identified previously only that they are at risk of peripartum hemorrhage. Maybe twin pregnancy, or maybe a patient has a coagulation disorder, or patient has, let's say, hemophilia or any other coagulopathy, or patient has any reason that patient can have a peripartum hemorrhage. Patient has a placenta previa, or let's say any other reason. So these patients, they should undergo a pre-anesthetic evaluation early. Early obstetric pre-anesthetic evaluation should be done. In that, the routine focus on the comorbidity of the patient should be taken care of. Some special things should also be done. So, in pre-anesthetic evaluation, antenatal anesthesia consultation should be arranged in patient at a high risk of peripartum hemorrhage. So, antenatal anesthesia consultation should be done in all patients who are at risk of peripartum hemorrhage, peripartum hemorrhage, and in patient in whom the blood and blood product transfusion can be it may be complicated. Maybe the patient are the patients who are not allowing the blood product transfusion, and in those patients we have to take care We have to plan for, let's say, how to minimize the requirement of transfusion by building up their HBs further, right? So taking all the care to minimize the requirement of transfusion. Who refuse